So I'll be speaking today again about high-grade spondylolisthesis. We have no relevant financial disclosures. So in terms of my agenda, I'm going to give you a brief background, really go over some of the controversies in terms of the treatment, particularly the surgical treatment, some surgical considerations, and then some case examples. So high-grade spondylolisthesis is a relatively uncommon condition, and this is somewhat complicated because this limits the studies that are out there, and they're all very low-level evidence. But when we see these patients, typically surgery is recommended. This is for patients who are having symptoms, pain or neurologic symptoms, and have undergone an appropriate course of non-operative treatment. And the optimal surgical technique remains controversial. So what do we know about the natural history of high-grade spondylolisthesis? So this is really the only study I could find with long-term follow-up in terms of natural history comparing non-operative versus surgical treatment. So this is Dr. Weinstein out of Iowa. He's better known for his work on AIS and the long-term follow-up of those patients. But in this cohort of patients which are grade 3 and grade 4 spondylolisthesis, he had 11 patients who were treated non-operatively, 27 patients treated surgically, 18-year follow-up for the non-op group, 24-year follow-up for the surgical group. And overall, he found that the patients who were treated non-operatively actually had fairly active lifestyles, 5 of the 11 of them being manual laborers. But in the end, at long-term follow-up, he found that patients who had surgery had improved symptoms over the course of time in 67% of those patients versus 36% in the non-op. So no real HRQOL, no patient outcome scores. This is a study done back in the 80s. Surgery for these patients was in situ posterior lateral fusion and then bed rest after surgery in the spica cast. So certainly an evolution of surgery over the course of time. And so, how does that compare to how we're treating patients today? It's a little difficult to compare because we know we just don't have 18-year follow-up on our non-op patients in this mobile society. We just aren't seeing our patients treated as adolescents coming back to the same clinic, 18 or 20 years later, and again, advances in our medical technology and how we treat and do fusions. So to go over some of the controversies, so first is whether we should instrument when we do surgery. So we know that instrumentation increases fusion rates, and in that aspect decreases the slip progression. Because in uninstrumented fusion, if you look at the review of patients with any type of spondylolisthesis, it's probably about a 40 to 50% fusion failure rate. And this also, again, avoids bracing or casting in the post-op period and prolonged bed rest. The other question is, should we and how do we perform circumferential fusion? So, whether you go anterior versus posterior, and we'll talk about when we go posterior whether we really need to do an interbody or some type of strut graft. And then ultimately, how many levels do you fuse when you treat high-grade spondylolisthesis? A UIV or upper instrumented vertebra of L4 or L5, sometimes considering L3. And then when you go down to the sacrum, whether you need to back that up with fixation to the pelvis. The other question is whether you perform a decompression, so a gill laminectomy, and particularly when you're doing reduction maneuvers. Patients who have neurologic symptoms, our thought is that you decompress these patients, perform a gill laminectomy, do foraminotomy, remove all the scar tissue from the pars area. But this study out of France, Dr. Roussely, he did reduction maneuvers and did not do a decompression, and he found that none of those patients ultimately had long-term neurologic deficits. In terms of another controversy is whether you do a reduction and what's more important. Is it slip translation versus slip angle? I think we understand that more important is probably the slip angle when it comes to lumbopelvic parameters. The cons of doing a reduction or trying to translate the vertebrae back is that clearly there's a risk of neurologic injury, and then the technical challenges and potential loss of fixation as you're trying to perform that reduction maneuver. The pros are that when you do the reduction, you actually create a larger surface area where you can actually perform an interbody fusion. Sometimes these high grade have a dysplastic dome or an area which is not suitable for an interbody graft, and also this improves the fusion environment. So often with the spondylolisthesis, that fusion area is in tension based on the weight-bearing axis of the body, and now you're able to bring it back and put it into an area of compression, and obviously it improves your lumbopelvic parameters as you do the translation. Another is a more radical procedure, which is an osteotomy or vertebrectomy, which is just remove that spondylolisthesis or spondyloptosis. Dr. Gaines published this series of 30 patients where he went anterior then posterior, removed the L5 vertebra from the anterior approach, and then went to the back and docked L4 onto S1. And he found that initially a lot of these patients, practically all the patients had some neurologic deficit, but at long-term follow-up, he's found that only 2 of them really required any bracing for their motor weakness. So this has had some, controversy because of the neurologic injury rate with this kind of radical procedure. But overall, his study and his outcomes showed that these patients do well. So I'll start transitioning into sort of where this has evolved. I think, my approach and what I've adopted in terms of what I've seen in the literature and in my practice is based on the studies and the procedures that were initially described by Dr. Bowman. So this is a one-stage decompression and fusion procedure, all posterior-based, where you place a fibular strut graft. And you can see the image here that this basically puts a skewer from S1 into the L5 vertebral body. And you can see here you typically use some type of guide pin and then use a reamer to ream out that area in order to fit the graft. And as we'll see, there's been both smaller retrospective studies which have kind of shown the benefit and the that this is a viable procedure, but also modifications to this over the course of time. And so in the past, they used fibula bone graft or allogeneic fibula bone graft. And you can see here, this is a study of just 14 patients. They found overall that these patients had good fusion rates and a safe technique, meaning that they did not see neurologic injuries, despite having to, if you saw that picture before, you're moving the thecal sac over almost completely across the midline in order to get this, to get the reamer and the graft in. And they did not find high rates of neurologic deficits post-op. This is the initial results coming out of the UCSF group with Dr. Bradford, and also results out of the WashU group. And in both of those studies, they found high rates of, the reason that it failed is because the fibular graft actually broke or it fractured before they achieved fusion. Here's another study out of Indiana by Dr. Sasso, and their sort of approach to avoid that fibula fracture is they actually did a side-by-side graft. So instead of going right in the midline, they modified it by providing 2 grafts from each side. So they thought you could first reduce the amount of dural retraction that you have to do. And then number 2 is that now you have 2 strut grafts going across that inner space, which potentially, if one provides more biomechanical stability and if one fractured, you still have another one there for additional support. Some of the modifications that have started to occur is that now they're using, in this study, they started using a metal cage. So they said to avoid the cracking of the fibula or the fracture of the fibula, we can consider using some type of metal cylindrical cage. So this is what I found was really the first study to describe that. As we go on, there's other where they would just place a screw, not necessarily a cage. And you can see here further modifications here out of Belgium. They looked at just using a screw. So they did what's called a transsacral screw. You basically place a screw from S1 into L5. And essentially, you can see here that they didn't even really put any graft or a large cage in there. They just placed a screw across there for stability. And you can see on the bottom right-hand corner, ultimately achieved fusion across that intervertebral area. So ultimately, this came to a modification, which is described by Dr. Hart in a series of patients where they modified this using both transsacral screws as well as the titanium cage that goes through the sacrum into L5.
No sublaminar cables?
No, yeah. So in that study, they found great results. Some of their failures, and I think Dr. Hart could certainly discuss this at the end of our talk, is that they tried some where they just put the cage and the screw, and they found that those were the patients that did not achieve success in their series. So some of the surgical considerations when we're thinking about these patients, so preoperatively, I think you need to look for spina bifida occulta. 70% of these patients were found in patients with isthmic spondylolisthesis by Frederickson. In addition, when you're getting imaging studies, certainly flexion extension views, and another view that I get that I find helpful is a prone lateral x-ray. And also a preoperative CT, I think, is mandatory, obviously looking at your pedicle anatomy, but also when determining your fusion levels, because your transverse process anatomy, I think, dictates somewhat of your fusion technique and ultimately what you're planning in terms of your grafting. Intraoperatively, it's positioning, so this is more an in situ fusion, but we do some postural reduction. You extend the hip and flex the knee. This is also to take your nerve roots off of tension. In terms of achieving sagittal realignment, you're trying to get some slip angle reduction or correction, is both with the sagittal rod contour, and also during surgery, you should do compression maneuvers on the back of the spine to help achieve sagittal realignment. In terms of L4 to S1 fusion, I think this is my what I've adopted as my go-to if I'm evaluating a patient, but I think there's consideration to stop at L5. First, if you can get excellent bilateral L5 screws, so a good L5 anatomy where you can achieve a good fixation, also large L5 transverse processes. So the literature shows that if you have 2 centimeters surface area on the TP, that this is probably adequate for fusion, but I haven't quite figured out how to measure that on a CT scan, but I think you just look at the overall anatomy, and I'll show you some examples in our cases of larger versus more diminutive TPs, and then patients with the low slip angle. Also, when you're planning, if you're going to place an L5 screw or you feel like the anatomy is appropriate, is making sure that you don't, in our typical screws, we kind of hub them or put them all the way down close to the facet. But as you know, L5 is going to be very anterior, and you need to place a screw that is probably about 10 or 15 millimeters longer than you would normally place, so you can actually seat the rod in without the rod being, without the pedicle screw tulip being too deep. And also for your S1 transsacral screw fixation, this goes through very dense bone. So if you saw those previous images, you saw that that transsacral screw went through 3 cortices. So that cortice that's in between that L5 S1 body is very sclerotic and very thick. So I think you get good screw purchase there. But I would say I would always have pelvic fixation on backup, just in case that, number one, the anatomy is not favorable, or you're not getting the fixation that you want, and that's just something to think about. And then with the modified Bowman strut graft, so instead of using the fibula, the benefits of the titanium mesh cage is you have a consistent size, so you know what size you're getting. You have a 10 or 12 millimeter cage. The ACL reamers for some of the providers or surgeons who don't do ACL surgery, so if, some of the neurosurgeons, the ACL reamers come in different types of reamers, and what I would ask for is a cigar-shaped reamer. It's more of a cylindrical reamer, and the problem with this is it's cutting on the edges of the reamer, and as you're trying to push back past that hard sclerotic bone, sometimes you got to push pretty hard, and obviously you're concerned about pushing the pin forward as you're starting to push the reamer forward. And then the under-reaming by 0.5 to 1 millimeters, what I found best in terms of getting a good fit of the cage without it kind of floating in there. Sometimes when you go line to line, I found in my first couple cases that I did this, that the cage didn't seem to have a nice press fit in there, and you worried more about the immediate stability of that. Other things that I look for are low versus high dysplastic features. So some patients, I don't do a modified Bowman graft in all patients. There are some patients with high-grade spondy or kind of the borderline 2-3 that, I would consider just doing an inner body fusion, but that really depends on their dysplastic features. If they have a dome sacrum, a trapezoidal lumbar vertebra at L5, those are probably indicators that inner body fusion may not be the best choice. Also, the severity of their lumbospinal pelvic parameters. So if they have a severe mismatch, they have a lot of kyphosis, I would say that I would probably not consider just an in situ fusion, because that patient down the road may have issues based on their spinal pelvic imbalance or mismatch down the road, especially for these younger patients that we're treating. And then obviously we talked about the reduction techniques. There's distorted anatomy. You're actually stretching the nerves is what is thought. And going in there to do the decompression where you're digging around the nerve root and, skeletonizing the L5 nerve root, which I think we've been taught in the past may be the way to reduce our injury to the nerve during our reduction maneuver, really hasn't been borne out in the literature, particularly in that study by Rusoli. So I think this decreases the complexity of the surgery by not having to go in and dig around and do a decompression of the nerve roots, even in the setting of a patient who may have some neurologic symptoms. So we'll go over some cases just as case examples. So this case, my first case, which is a 24-year-old male. He's a Air Force service member. He's a C-17 crew chief. I don't know if any of you know what a C-17 is. It's a huge plane where they put tanks on. And so, he does a lot of heavy lifting, does a lot of manual labor type work. He's got severe back pain, bilateral radicular symptoms, intermittent numbness, tingling, and really has gone about 2 years of undergoing non-op treatment. First, they clearly didn't know what was going on. Then they're treating his back pain through physical therapy and other modalities. And ultimately, he's otherwise healthy and didn't have any really findings on his motor or sensory examination. So this is him preoperatively. We can see that slip angle, he's sort of a borderline 2-3s, right? I would consider him about 55% slipped. And you can see that his L5S1, that the slip angle is kyphotic. So he's got 6 degrees of kyphosis. And overall, his lumbar lordosis isn't all that mismatched from the pelvic incidence. So in terms of his lumbar pelvic parameters, he does have some retroversion of his pelvis because as his pelvic tilt is fairly high, but overall his mismatch isn't that high. And this is probably a good candidate for someone to do an in situ fusion or postural reduction. So what we see is that with flexion extension, it actually doesn't move that much. And this is before I was getting pro and lateral radiographs. And you can see on his MRI, he's got some foraminal stenosis, but that's typical of this type of patient with a pseudodisc uncovering. And then ultimately we took him to the surgery. We did the modified Bowman procedure. And this is the first time that I did this. I did this with one of my partners, Mark Minoso. And, in this case, we didn't do the transsacral screw. And I think that's sort of what prompted my thought into looking at the different techniques, because as we're placing this cage, it was sort of pushing the L5 vertebra anteriorly. And, it was more translating it forward, which obviously is sort of defeating of what we want to do, is trying to reduce it and try to tilt it back. We got our postural reduction, and so we found some difficulties putting in this cage. And I think the benefits of doing the transsacral screw is that it actually holds it in place while you're putting the graft in. And we did an inner body fusion at the level above. So ultimately, when we look at his slip angle, we see that just with postural reduction, we got about a 12-degree improvement of his slip angle, and his lumbar lordosis did increase by about 4 or 5 degrees. So this is another case, a patient with Marfan syndrome, 14-year-old. He's got some ligamentous laxity. He's had ongoing severe back pain with activities in sports. He's actually experienced some upper buttock pain, but no real radicular symptoms. He does have some, he has a pectus deformity, and the remainder of his workup in terms of coexistent medical problems with his Marfan's was normal. So you can see here that he's got about an 83-degree slip. This is more of a dysplastic spondylolisthesis. His slip angle is 16 degrees, so he does have quite a bit of kyphosis there. And you can see that his lumbar lordosis mismatch compared to his PI is close to 20 degrees. And we suspect that most of this is coming through that L5S1 slip angle or through the L5S1 kyphosis. You can see here with flexion extension, and then standing and prone. And I'll show you some x-rays later on why I feel the prone lateral x-ray is important, because it shows you that how much reduction you probably can get in the operating room. You can see here there's more of a dysplastic feature, meaning that there is a pars defect, but the other side just has a very elongated pars. And we talked about the transverse process. So this case is a little unique because it's a pediatric patient, and you can essentially expose these patients and they're going to fuse. But still, there's a challenging environment even for the pediatric patient down at the lumbosacral area. But his L4 transverse process is fairly large, but you can see his L5 transverse process, which is very diminutive. So in this patient, these are intra-op fluoroscopy. We did a modified Bowman procedure. We did our transsacral screw with our modified titanium cage. And you can see in this patient, we did not do an inner body fusion because of his large L4 transverse processes, which we thought we can achieve a lateral fusion. So you can see here that postoperatively, we feel like we got a slip angle of minus 12 degrees. So overall correction of almost 25 degrees in this patient from pre-op in terms of the amount of kyphosis at the lumbosacral junction to postoperatively. And you can see that just on the prone x-ray, the slip angle, we went from 16 to 5 degrees just on an awake patient in the prone position. So this really indicates to us that we could likely achieve a postural reduction in this patient. And ultimately, he's gone on to fuse and has done well and back to his activities. Another similar case where we look at a patient, an adult patient, 34-year-old with back pain, similarly with a high-grade spondy. We have flexion extension films here as well as with prone. Again, pseudo-disc uncovering. You can see here that the sclerosis I was talking about at the L5 and S1 end plates at the junction there. And these are just some intraoperative radiographs. I think the main thing is exposing wide in these patients. You have to expose more distally than you expect. Also, when you're doing your laminectomy, oftentimes that area is actually, the ligament of flavum is stretched out because of that, the spondylolisthesis. And the amount of laminectomy you have to do at S1 is probably not as much as you think, but certainly you have to expose up to the lamina of L4 as well and do a gale laminectomy. So here's just some more x-rays of a procedure that we did. And here's we do intraop CT scan. This is just another image where you can see that the graft is going across the intervertebral space. And sometimes you get into some crowding, so a crowding of the area where you're putting the screws in as well as the cage. And ultimately, we didn't get much of a slip percentage reduction and went from mid-80s to 80%, but our slip angle decreased to 23 degrees. And you can see here that overall, this patient had a lordotic L5-S1 segment from the pre-op radiographs, but we increased that by about 13 degrees just with postural reduction. And overall, our lumbar lordosis also improved compared to a PI. It's very close. And finally, there's just a little bit of a different case. This is a 2-3 borderline high-grade spondy. So some may classify this as a grade 2, grade 3. I think you have to think about it in the same principles. You can see that she really doesn't have much sacral dysplasia, so the sacral dome looks relatively flat. And in terms of her pelvic incidence, it's a little bit, or pelvic tilt is a little bit more retroverted. So this may be more difficult to really get that modified Bowman, and not everyone's a suitable candidate for that. So in this patient, she didn't move too much with flexion extension films. She really had a lot of bilateral radicular symptoms. And I think for her, trying to achieve a more indirect decompression, particularly based on her symptoms, was what we're trying to achieve. And you can see here that there appeared to be a suitable amount of surface area, and the anatomy of the sacral dome, again, appeared appropriate for inner body fusion. Also, in terms of looking at her anatomy, so we can see that both for levels at L4 and L5 have fairly diminutive transverse processes. So for her, we're really going to rely on that inner body fusion to achieve fusion through that segment. And going up to L4 probably wouldn't have helped our cause much in this case, just because getting posterior lateral fusion in that patient also would have been probably not as likely. So you can see here, we just did a standard L5-S1 transforaminal lumbar antibody inner body fusion. And you can see here we achieved adequate results. So in summary, I think there's a lot of controversies which remain for high-grade lytic spondylolisthesis. I think each case is unique. I think you have to look at the imaging carefully and consider and prepare for different approaches and techniques. Thank you.
Outstanding. Great presentation. Thanks for coming up. Time for some questions. The first question I'll start off with is, great cases, beautifully done. When you face a patient with a high-grade spondy, what do you tell them about the risk of an L5 policy in terms of percentages and, again, the natural course history over time in terms of if it happens?
Sure. So for the first question, I think in terms of natural history, I think what we have in terms of our natural history studies with Weinstein, those patients didn't ultimately have neurologic progression. But I think that study kind of is biased based on the selection, because the patients who may have had ongoing symptoms or developed symptoms may have gone on to have surgery. So those patients may have been lost to follow-up, and we don't know about that in terms of the selection bias. But I think the rate of ongoing progression, especially in adults that are diagnosed, is low. And I think the onset of back pain and the advancement of neurologic deterioration is relatively low. But then we start talking about surgery. I think when we discuss reduction reduction maneuvers. I think for most patients, if you look at the literature, it's probably about a 20 to 30% transient nerve injury rate, but most of those patients recover. So I'd say there's a very low likelihood that you'll have permanent neurologic deficits, but there's always a chance postoperatively that you will have some either pain or motor weakness.
So why does it happen? Can you just clarify to us? Why do, aside from a direct surgical trauma, God forbid, why do these high-grade spondies have such a high rate of L5 temporary or permanent root pathology?
I think that's really unknown at this point. I think clearly there's compression from that pseudodisc. There's pars tissue that's compressing on the nerve. And if you look at all the MRIs that we just showed, that area is very small, so the vascular supply to those nerves may just be diminished. And even a little stretch injury as you're kind of reducing the spondylolisthesis may be enough to really kind of tip it over the edge in terms of the nerve function.
What's the stretch tolerance of the L5 root?
I mean, I think you just look at it and it's going to potentially not like it. So I think I don't think we know exactly how much it can stretch before it really becomes, before it has any effect on the nerve.
Bob, you've studied this subject. Postaccini had kind of a little quantifier about L5 tension, so reduction versus non-reduction, and is there kind of a known stretch tolerance of the L5 root based on Postaccini studies?
I mean, I guess I'm not familiar with the study you're referring to specifically, and I don't have any kind of solid numbers that I would be able to sort of use in practice. But I think the listhesis reduction is more dangerous than the angular reduction. So the kyphosis, and I think that the functional outcome depends on the kyphosis reduction more than it does the slip reduction. So if you adequately decompress the nerve roots and you get them solidly fused and not in kyphosis, then that's what you want as your result. And then besides that, I think reducing the amount of surgery, and you see patients come in with 3 to the pelvis fusions for these, and I think that's not necessarily a good service if we can avoid that. So that's I think the goal is reduction of the angular slip, and I also think we didn't completely know that. A lot of the older literature, and Dr. Bowman's series has a number of patients that he fused in kyphosis. That also takes 20, 30 years to become symptomatic, as the slip itself does for some of these patients. So I think the natural history data is very suspect, as you say, because 18 years may not be enough. I don't know.
Jeff, you've heard an argument for modified in situ fixation. Bob has written one of the landmark articles about this. Where do you stand now in terms of trying to get these patients happier? Is reduction an issue? And if so, what reduction?
So it sort of depends on, I think, the grade of the slip as well as how much reduction you're trying to get. I think there are 2 different camps. Some people believe in situ, some people believe in reducing. I take a very different approach to this, and a lot of the MIS guys are doing the same. I think that instead of the traditional teaching for this is clearly like going from 4 to S1 or to the pelvis. But I think for MIS, it's really more about getting an inner body into that space and getting at least 1 or 2 grades of reduction, but also making sure that you have a full decompression of the exiting L5 nerve root. I think that's really the key, because if you take a look at a lot of CT scans and CT myelograms and even the MRI scans, you can see that a lot of these L5 nerve roots are entrapped a lot of times with bone from either the disc osteophyte complex or from the facet joint itself. So if you follow out, the entry and exiting zone of the L5 nerve root is quite wide. So you have to make sure that you take it from the axilla all the way out to the exiting to make sure that the L5 nerve root's fully freed before you make that reduction attempt. But typically the way we actually have one of these cases today, I believe, like the second case, where you go and do a complete, almost a foraminectomy, and then do proper interbody preparation, put a cage and try to get at least 1 or 2 grades of reduction using a reduction maneuver.
So you don't go anteriorly, you do go anteriorly?
I go just purely posteriorly.
Yeah, so that's remarkable for an MIS guy. Have you done these anteriorly?
I have not. I feel like the approach from talking to other surgeons is very difficult. I mean, their pelvis is typically very tilted back and trying to get that exposure into that disc base. And I think you really need to consider doing the reduction first before you would go forward, not for maybe the grade 4 or spondyloptosis, you know, the grade 3, trying to get the reduction first before you'd consider putting an interbody graft in the front.
Yeah. I can give you a little historical vignette. Dr. Gaines was a visiting professor in Dallas at TBI, and he was invited to do one of his vertebrectomies for high-grade spondy. They had actually 3 cases lined up, and the first case was an absolute disaster with massive bleeding, bilateral foot drops, and they then basically said, and Bob Gaines is the nicest guy on the planet, said, let's not do that anymore. And it was just, again, the anatomy in these high-grade slips is unbelievably hard when you're trying to go in anteriorly. So that was kind of always, for us as residents who were in the room there, it was just like, wow, this is bad stuff. So I've had a healthy respect for that. In terms of the Posticini article, it's a great article because they basically put shoestrings into the roots and then they played around with the angles and they replicated the tether anterior to the sacral ala of the L5 root. So they say about 3 millimeters. But again, intraoperative assessment is what I always thought matters more. But they said about 3 millimeters, maybe 5 millimeters translation, but somewhere in that gray zone. As you're right now practicing again, so the variables are significant. You brought us some very helpful ones. Where do you now stand if you have a true grade 3 or 4 spondy? And again, this patient is pretty stable on flexion extension films. He has clear L5 pathology. How much reduction are you going to do in terms of what you're going to do? Is it a Bowman right off the bat, or are you going to try to pull it back a little bit?
Again, yeah, I think we need to take into, I think everything comes back to lumbosacral parameters. So you look at how much lumbar lordosis they have, if that segment's actually in kyphosis. And so based on looking at if they have the appropriate anatomy for a Bowman graft. So yeah, I think if their PILO mismatch is, 20, 30 degrees and they have already some fixed sagittal imbalance, just maybe they're older patients, maybe a 40 or 50-year-old who has more degeneration, I'd probably consider more of a reduction technique in those patients. But certainly for our young patients who have maintained compensatory mechanisms, I think I would approach it with kind of what we've discussed today.
Great. So we have to come to a close, clinical duties call, but Daniel, thank you so much for coming.